Hello everyone, I'm Dr. Susan. I'm a liver transplant anesthetist and intensivist, and I'm quite happy to meet you all through this platform. Today I will be talking to you about perioperative deep vein thrombosis prophylaxis. I feel this is a very important topic as a perioperative physician. So we mostly tend to concentrate only on the intraoperative management part, and then such important things get missed when it comes to the holistic approach of patients during the perioperative period. Quickly, I would be sharing today about how to assess the patient preoperatively, how to get prepared even prior to the admission of the patient, and how to design your prophylactic strategy and prevent such complications from happening in the preoperative period. So, venous thromboembolism, which broadly includes both deep vein thrombosis and pulmonary embolism, was first described by Rudolf Virchow in 1858, and the possible mechanisms for this event has been attributed to three mechanisms: pathophysiology, basically, venous stasis, injury, and hypercoagulability. So this has come up as a more frequent and preventable cause of postoperative morbidity and mortality. And the incidence currently recorded is around 50%, especially in the hospitalized patients. So pulmonary embolism is the main fatal event which happens as a complication of deep vein thrombosis, which can further lead to post-thrombotic syndrome, pulmonary hypertension, and heart failure, which are all known consequences of this complication. So, looking at these catastrophic consequences, it is better to prevent the venous thromboembolism with antithrombotic therapy. But the problem is to make sure that it is balanced with the postoperative bleeding risk, which is our greatest concern in the perioperative period. So when talking about deep vein thrombosis in the extremities, the upper limbs and the lower limbs, this diagram is showing a bunch of venous drainage. So it can be anywhere from the central to the peripheral systems. You have your IJVs, you have your subclavians, cephalic veins. It can be in the axillary, brachial, and it can be in the paired radial or the ulnar veins, and even in the interosseous vessels. When looking at the lower limbs, you have the femoral veins, the popliteal, the posterior tubular, anterior tibial veins, and the fibular veins in the lower extremities. So how do you approach perioperative VTE prophylaxis? So this should start even prior to the hospital admission. So this happens when you are looking at the patient at your pre-anesthetic clinic. So you do your full history and physical examination. Now you will get an idea about how much risk the patient stands to gets exposure to because of venous thromboembolism. So then you pick up the modifiable risk factors and then try to address them so that you can decrease the perioperative risk. You should also take the initiative to discuss with the surgical team, the patients, and the family, and then make a strategy appropriate to the patient and his risk, formulated even prior to the admission process. And when the patient comes for admission, you reevaluate the risk of thrombosis and bleeding 24 to 48 hours prior to the surgery, and then get your prophylactic strategy in place and get it started. Okay, so it is not just the surgeons or somebody else's duty to do all these things. The anesthetist, as a perioperative physician, can get all these things initiated and going. So how would you assess the risk of thrombosis in any patient? So there are a lot of scores available. You can do this baseline assessment using CAPRINI score, and there's one more score they call the Wells score. And there are certain surgery-related specific risks, and there are some perioperative risk also, which we will look at in detail in the following slides. So this is the CAPRINI score, which was introduced by a surgeon, Dr. Joseph Caprini, quite some time back. This has been in place for almost more than 2 decades now. So this looks at a lot of things are there here. So there are some risk factors which are given 1 point, some risk factors which are given 2 points. There are risk factors which are given higher points, such as 5, and the total risk factor is then taken into consideration. So you can look through these risk factors, and then you can see that age, the type of surgery, and then preoperative disease patterns, or comorbidities, or issues such as varicose veins or inflammatory bowel diseases, and then other concerns such as obesity, are all given importance to. And then some specific disease-related factors such as family history of thrombosis or factor V Leiden mutation, prothrombin levels, or prothrombin mutations. These are all some specific factors which will be applicable to specific patients who will be coming under high risk categories, who will be given points according to this score. In women, even the usage of oral contraceptives or hormone replacement therapy, pregnancy, postpartum period are all considered specifically in women, and they will be deemed as high risk for prophylaxis or high risk for thromboembolism based on the scoring systems. So as per the CAPRINI score, this is the risk stratification, the estimated risk for thrombosis without the prophylaxis. So you can see that general surgery, plastic, reconstructive surgery, ENT, gynecological, vascular, and surgical ICU. So multiple major surgeries are mentioned here. And then as per the increasing score, the risk of thrombosis is also higher. And then patients who are at the extremes of the spectrum would be required to put on prophylaxis to prevent the high risk of embolism and thrombosis. So again, another frequently used score is the Wells score, which takes into consideration disease processes such as cancer or paralysis, paresis, cast immobilization, or being bedridden, localized tenderness, swelling, and collateral, superficial vein edema, swelling, such as non-varicose, and the previous history of DVT. So these are all some risk factors, characteristics that are looked at the Wells score. And based on this scoring system, you will be classifying the patients as either high or low risk, or they have two types of classification, 2 risk classification, 3 risk classification. So based on this, you can score and then stratify your patients and then plan for prophylaxis. It is not possible to remember the entire list, and it is not required also, because these are all easily available, the calculators are available, but it is important to know what to look for in your patient so that you can assess their risk and then accordingly be prepared to deal with the complications intraoperatively and postoperatively.